webinars developed to assist Florida's family physicians and their staff in dealing with this COVID-19 crisis. Tonight's topic, an update on telemedicine for family physicians. It's timely, considering most of the questions received by us have been from members focused on how to practice in what has literally become a virtual reality. Stay tuned for more information regarding next week's topic, Thursday, April 2nd. It'll be best practices and perspectives from Florida's family physicians. Before we start, please remember all participants are in listen-only mode, but can type questions that our speaker can see and will attempt to answer either during or at the end of the presentation. Now I'll turn the program over to our presenter, Dr. Julia Jenkins, who is Assistant Director for the USF Family Medicine Residency in Tampa and also serves as Vice Chair of the FAFP's Continuing Professional Development Committee, which oversees all of FAFP's educational activities. Dr. Jenkins?
Thank you so much, Jay. First, I just wanted to say thank you all for being up with me tonight. We're going to talk about a very timely and what seems to be a very important topic tonight about telemedicine and the basics that you need to know to get started. So as Jay said, I'm Dr. Jenkins. I'm full-time faculty at USF's Family Medicine Residency in Clearwater. I've been privileged to be teaching telemedicine to the residents here for several years because we've been developing a telemedicine curriculum, and I'm certified as a telehealth facilitator. I also wanted to mention the other contributors to this webinar, Dr. Chris Scuderi, who is faculty at UF College of Medicine in Jacksonville. He's our FAFP COVID-19 director and has been just incredibly helpful in working hard to make sure that Florida's family physicians have good resources in facing this pandemic, and this is updated every day. And then Dr. Julie Brady Roberts, who is a friend and colleague here practicing here in Clearwater. She works for the same healthcare system that I work for called Baycare. She's one of their administrators and clinical informaticists, and she was actually going to be teaching the FAFP membership about how to do telemedicine during a workshop at the Spring Forum. Unfortunately, that workshop had to be canceled, and so she's here to lend her expertise both from an administrative perspective, but also from an IT and health system perspective. So the objectives that I hope we accomplish in the next half hour is how to give you the basic telemedicine information you need to be able to help your patients during this pandemic. And we really want you to be able to quickly implement telemedicine after listening to this webinar. We're obviously going to talk about the very recent telehealth regulatory and payer policy changes that have occurred because of the pandemic, but really I think the overall objective of this webinar is to help all of you as family physicians feel like this is a very viable and a very reasonable option for caring for your patients and providing good medical care at a distance. So usually when I'm teaching telehealth to the residents, I spend a lot of time talking about the benefits of telemedicine and why we should embrace telemedicine. I think we're past that. You know, this is not a should we, it's we need to be doing this and why didn't we do it sooner? So we're going to talk a lot about this so you all feel more comfortable, but I think all of us as physicians have seen in the past week that this COVID-19 pandemic is escalating and very uncertain as to the projection over the next several weeks and months. And so it's very, very important that we do everything we can to keep our patients at home. So when talking about telemedicine, there's some basic terminology that we're going to use and that you're going to want to know to understand the legislation and the billing better. So telehealth and telemedicine are terms that unfortunately are kind of used a lot interchangeably, but in general, telehealth tends to mean kind of an all-encompassing term for different types of remote health care, like telemedicine. So telemedicine will often refer to the live video visits, and that is a synchronous type of telehealth modality. So synchronous meaning live in real time, and phone conversations and kind of EICUs and virtual consults would also be considered a synchronous type of telemedicine. You also have your asynchronous telehealth, and that's the type of medicine that we do for free all the time when your patient sends you an email of their rash or forwards you a picture of a family member, but that is an asynchronous where you're getting some type of health data and evaluating it later on. Radiologists are very good at this and looking at images that are asynchronous, and our patient portal messaging would also be considered an asynchronous telehealth. And in the past several years, hospital systems and other healthcare providers have been embracing something called remote patient monitoring. And what that is when your patient is recording some kind of health data at home, and then that data is forwarded to a clinical team or to a physician to be evaluated. For example, in our CHF remote monitoring program, your patient can video chat with a nurse or record their weights or their blood pressures at home, and then that data is forwarded for evaluation. And then finally, in the world of telehealth, there's a lot of companies that are capitalizing on something called mHealth or mobile health. And the thought there is to try and put telemedicine and put it in the hands of the consumer, in the hands of the patients, so that patients are tracking their own health data with things like Apple Watches that monitor our heart rhythm now, things like Fitbits or mobile apps that help to record, your sleep, your diet, your weight, or even these wearable blood sugar devices like Freestyle Libre and Dexcom. So telehealth has been growing, but had been kind of slow to start until just a few weeks ago. And very, very recently, the government and CMS had come out with this legislation, very lengthy title, called the Coronavirus Preparedness and Response Supplemental Appropriations Act. And CMS and the government out of that enacted the 1135 waiver authority, basically saying that we can do a lot more with telemedicine because of the pandemic than we've been allowed to in the past. And so telemedicine used to be restricted to rural areas and to certain situations. Now we can provide telehealth and telemedicine services to patients in urban areas, to patients in their homes. And then there's other types of allowances with this law. I will mention that the new legislation and this 1135 waiver is specific to Medicare, and we're going to come back to that because you do have to be mindful about which payer you're talking about in reference to telemedicine. So out of this waiver, we can also provide telehealth to new patients. So you don't need to just provide telehealth for Medicare beneficiaries that are established with you. You can also see new patients, and physicians at their discretion can reduce or waive cost sharing. And very importantly, that for Medicare beneficiaries, this legislation did not include coverage for telephone communication, and those are the associated codes. I will tell you too that each one of these slides, I tried to put a link at the bottom with the reference, because although this is true of this week and today, this is changing pretty rapidly, so you want to make sure that you continue to look at the FAFP website. So Medicare coverage under this 1135 waiver really is covering three types of telehealth or virtual services. And so the first of that is telemedicine visits, the live synchronous visits that you would do via video. Not only, if you look to the left, not only does that include kind of your office visits, your routine follow-up visits, but that also includes for Medicare annual wellness visits, your first and your subsequent wellness visits. It does not include the initial Medicare visit. You can also do telemedicine for transitional care visits, for advanced care planning, and then for a lot of the Medicare screening and counseling codes that we use on a regular basis. The other two types of visits are virtual check-ins and e-visits for Medicare beneficiaries, and we're going to talk more about those two. But I want to talk a little bit about Florida Medicaid. So it's up to each individual state whether they enact this 1135 waiver. Florida Medicaid did enact the waiver, but it doesn't cover the same services as Medicare does. So Medicaid here in Florida will cover for telephone communication type telehealth, but they have not yet approved coverage for the video visits. Most payers have, and so I would anticipate that that may change pretty quickly, but as of right now, March 18th, that has not been said that they were going to reimburse for that. They do reimburse for store and forward, like patient forwarding you a picture or health data to be evaluated. They do cover for remote patient monitoring, which we'll talk about. And then other services, which I put the link there, but I'm trying to talk to you guys about services that are the most pertinent to family medicine and to outpatient family medicine. This is just showing you the reimbursement for the telephone communications, which unfortunately is not quite equivalent to the video telehealth communications, which we'll talk about in a future slide. So if you're going to be billing basically almost for any payer where you're doing a live video telemedicine visit, you need to have video, and that's kind of what the current legislation is saying. And for those of us that practice in Florida and have a lot of snowbird patients that sometimes reside up north, while you're performing the telehealth visit, the patient needs to be in Florida. So even if they're an established patient with you, they physically need to be in Florida. What's also very helpful with this new legislation is that providers can prescribe controlled substances via telemedicine, not just for established patients, but also for new patients. So that includes all Schedule 2 to 5 drugs, opioids or not opioids. So when you're setting up your telemedicine video visits and you're thinking about what types of patients you're going to be seeing via video, there really is 3 types of patient encounters that you're going to be scheduling and preparing yourself for. And one type of visit is going to be your triaging for COVID-19. For those of us that work for large healthcare systems, they may already have clinics or hotlines or things in place to be doing triage, but if you don't have that, telemedicine offers a really nice way to talk with your patient safely, to determine if they need testing or if they need to be quarantined, or to even think about if they're not, they don't really sound like COVID, you can give them counseling or decide if they need to be seen in person to determine if it's some other type of etiology causing their symptoms. You can also use telemedicine to see your non-respiratory acute visits. And so for those of us that have been practicing telemedicine for a while, we realize there's a lot of conditions that you can see via video fairly comfortably. So I put a few examples there just so you can start to think about what would be appropriate via telemedicine. And we'll talk about what will happen if you're doing telemedicine and you decide they just need to come in. And that would also include, again, just to reiterate that would include your hospital follow-ups for your Medicare beneficiaries. And then finally, before the webinar, there was questions that came in and people had asked, well, I definitely can see that we would want to cover acute concerns or urgent concerns, but are they going to reimburse for follow-up visits? And the answer is most payers will, and we're going to talk a little bit more about that. But as you can imagine, our patients that have chronic medical issues, our diabetics, our patients with COPD, our patients with hypertension, even if they're scheduled for a routine follow-up visit, very likely there's going to be acute concerns or a medication that needs to be evaluated. And so it's definitely appropriate to be doing telemedicine for those patients during this time. And again, that also includes your annual wellness exams and your hospital follow-ups. So what's nice about the new telehealth legislation is that they have made the billing portion of it fairly simple, in that you can bill the visits, these live visits, very similarly to how you bill your in-person visits. And so if you're seeing a patient for what would qualify as a 99213 for your established patient, you would bill a 99213, but add a modifier 95. And so the modifier 95 is telling your payer that this was a synchronous live telemedicine visit, and that's for most payers. So if you add that modifier, that signifies that's what that is. And then you can bill based on complexity or based on time. And I put the times there for your reference. And we did receive a question before the webinar on, how do you document for your telemedicine visit so that it supports the level of billing? And basically my advice would be that you would document how you would document in person. And I think this question comes from the nervousness of not doing an in-person physical exam. And we're going to talk about that a little bit, because there really is a lot of elements that you can document with a virtual physical exam that'll help you meet the level of complexity and meet the level of billing for billing a 3 or a 4. So I put some information there on billing level 3s and 4s, kind of based on what we do when we see patients in person, but that also applies to telemedicine. And I did also want to say that you could just bill based on time as well, but if you're in an academic setting like I am, you wouldn't want your residents or your fellows to use codes based on time. This is kind of a summary as of today, and I've had to change this slide almost on a daily basis as to what commercial insurances are reimbursing for telemedicine. So most commercial insurances are reimbursing for the video visits or the telemedicine visits. And this does change quite often. And so I would encourage all of you to just continue looking at that FAFP website for the most current information. I think most payers are kind of getting to a place where they're going to be reimbursing, but we'll have to see. And it varies even more. I think it's safe to assume that most payers are going to reimburse for these video visits, but as far as a phone visit or a check-in or an e-visit, that really does vary quite a bit based on the payer. So I talked about it a little bit, and I wanted to basically discuss the elements of what's called a virtual check-in. And a virtual check-in is under this waiver 1135, and is for Medicare patients, but also for some commercial patients. And basically you're having a brief phone or audio, video, or message interaction with your patient to determine if they need to come in or if there's something you can manage remotely without having to see them. And so the caveat to using a virtual check-in code is that it does have to be initiated by the patient. However, you can, as an office or as a provider, solicit this by letting your patient know that this is a service you can provide if they would like it. And a couple things related to this code is that the complaint that you're managing, or the medical issue you're managing, cannot be related to something you discussed with them at a different medical visit within the previous 7 days. Or if you're doing your virtual check-in and you decide that they do need to come in, it can't lead to a medical visit within the next 24 hours. So the virtual check-in code is down below. And there's also a code there if you're going to do a remote evaluation of a patient image or a patient video, which in the telemedicine world is called store and forward. And then the third type of visit that the new legislation is allowing for is something called a Medicare e-visit, or an electronic visit. And basically this is your patient portal type visit. So you have a patient that sends you a portal message through the electronic medical record, and this does have to be for established patients and mainly Medicare patients. And you're addressing something and managing something via the portal. And so this is a time-based code. And as you can see below, there's the details on the payment as of 2020 and the time requirements for those codes. And again, this is a 7-day period attached to this. And so if a patient emails you every day for a week, you would only bill this once for the week. I wanted to briefly talk about remote patient monitoring because this is also something that's being reimbursed. And so just a brief example is if you have a patient that has COVID-19 or you suspect has COVID-19 and you want them to monitor their pulse oximetry at home to help you determine if they should continue to quarantine or if they should go to the hospital, you can bill for remote patient monitoring, and you would use 2 codes. So the 99453 code is the patient education of what parameters to look for and how to record their pulse ox and how often to do it. And then your 99457 code is your evaluation of that data and your management of that data. So I wanted to go through a couple telehealth billing scenarios just so we can kind of think about the legislation and how that applies to your day-to-day using telemedicine. So let's say you're trying to connect with your patient via a live telemedicine visit and your video or your audio is just not working. And so this will happen, and you cannot bill. So some providers will want to switch from a video telemedicine visit and then just bill for a phone visit. But if it's a Medicare patient, they do not reimburse for phone visits. If they have Medicaid, that's reasonable because they do reimburse for that. Also, if you have video but your audio is not working, you definitely could try to contact your patient via another phone number and use audio from a different device. And so as long as you have the video and audio in some capacity, you could bill. And you also, if you're having difficulty with the video and it's a Medicare patient, you could just call and ask if they would prefer to have a phone check-in. And so get their consent to do a phone check-in, and you could convert the billing to a phone check-in. So let's say you're doing a phone check-in and you determine after talking to the patient that an office visit is needed in person in your office. And so you do not bill for a virtual check-in if the patient needs to come into your office within 24 hours. So you would not bill for both. You also wouldn't bill a virtual check-in if it's a concern that you and the patient talk about that's been discussed at another visit within the previous 7 days. And so another scenario would be your patient has a commercial payer like Florida Blue, and they contact you via the portal or a phone conversation and they'd like advice. So again, Florida Blue is covering for video telemedicine at this point, although that will likely change, but they're not reimbursing for phone or for portal messages, and so you would not bill if it is phone or portal advice. And then the last scenario is if you're communicating with your patient via the portal for an e-visit and you determine that your patient needs to come to the office later in the week to be evaluated in person. So you cannot bill for an e-visit and an office visit for the same issue within a 7-day window. So you just have to be careful about that 7 days. But if you're doing an e-visit and then you do an office visit the next day for separate issues, you can bill for both of those. This is really here mainly for reference, but just to touch on that if you're seeing patients that have potentially been exposed to COVID-19, but they have maybe have COVID-19, but they don't have a confirmed diagnosis, your primary ICD-10 code would be the symptom, the main symptom they're presenting with. Once they have a confirmed COVID-19 infection, there are specific ICD-10 codes that you would use, and then also specific codes for possible exposure. So I intentionally talked about the billing and legislation right from the beginning to kind of get to the meat of this webinar, but now we're going to talk about just some basic things you would need in your office if you wanted to get started tomorrow doing telemedicine. You basically just need some type of device or hardware that has a video and audio capabilities. And so that could be a desktop computer with a webcam and a headset like you see there on the left. It could be an iPad. So we have several iPads on stands that allows you to do your virtual visit and also document in your EMR on a separate screen. You can also use your laptop. You can use a telephone. So there's a lot of flexibility. Ideally, you want to use Wi-Fi. Connection should be a concern. And make sure that when you decide where you're going to be doing your telemedicine visits, that whatever is behind you is professional and that you're in a private, well-lit space so that your patient can see you well. Also, be mindful of how you're going to document and do the visit. And make sure your staff is checking on the equipment and making sure it's charged and updated so that you don't have to troubleshoot that as you're trying to take care of people. Also, a really good advice is ahead of time before these visits to get a good contact number for the patients because technology does fail at times and unfortunately with telemedicine more often than we would like. So having a backup number is very helpful. So with the new legislation, we're able to use a wide variety of software programs to be able to do our video telemedicine. And I put here just a list of some of the common programs that physicians are using to do their telemedicine visits. Some of them are free and some of them have a cost associated with them. There's a link to the AAFP website where they have descriptions of different software programs you can use. The caveat with the new legislation is that you should absolutely not use some type of video software that may be accessible to the public or public facing. And so things like Facebook Live or Twitch should not be used. The other thing when you're starting to call your patients and schedule telemedicine visits is thinking about having a script for your staff or some type of instructions or brochure that you can mail to your patients so that they understand the process better or they understand basic concepts about telemedicine better. It definitely helps to have a champion in your office that understands the patient side of the process very well, and it helps to practice and have trial runs so that you can see from a patient perspective what some of the barriers may be or some of the more complex things may be. And this is talking patients into doing a telemedicine visit is a lot like trying to get our patients to do vaccines. It's all in the delivery and how you talk to the patients about it. And so when I'm telling patients about telemedicine, you will get patients that are kind of nervous about it. And I say, if I can see you by video, as a physician, I'm well trained to have a clinical intuition about certain medical conditions in the way that you speak, in the way that you answer questions, in some of the expressions that you're making. And so you really have to just reassure them that this type of healthcare delivery it can be very helpful. And then what I found to be very helpful in doing telemedicine is at the end of the visit, solicit from the patient, did you like this? Did this work for you? Or did this not work for you? And they're going to give you some really good feedback about how to do this better and who this may or may not be appropriate for. I'm very glad to be able to share with our Florida family physicians a resource that was provided by American Well. One of their medical directors, Dr. Mia Finkelstein, is allowing our physicians to access for free physical exam training videos. And so I think that's one of the things that residents tend to be the most nervous about when we're teaching telemedicine is how can you provide medical care, how can you do a good physical exam remotely with video. And so there's a lot that you can have your patients assist with, and there's a lot you can see with the camera, and it's pretty surprising once you start to do it, the information that you can acquire. And so, for example, one of the things you'll see in the video is how to educate your patients how to feel for lymph nodes. And you want to use very simple terminology like, are you feeling anything that feels like a grape? Is it the size of a grape? Is it smaller? Is it bigger? And kind of just guiding them through the process and using very simple terminology. This is not meant to be read to you, but it's just meant to be a reference because this can serve as kind of a dot phrase or auto text for your electronic medical record and gives you an example of what documentation can look like for a telemedicine physical exam. And so there really is a lot of organ systems that you can document there that would be very, very helpful in justifying your billing. And then because I am in an academic setting, I wanted to touch very briefly on what ACGME has said about telemedicine during this pandemic. And so the ACGME is allowing residents and fellows to care for patients via telemedicine, and that can be with indirect supervision if they're deemed capable of doing it. If there is situations where direct supervision is required, the faculty can provide that direct supervision through telecommunication. So you don't have to be standing next to the resident during the telehealth visit. You could video chat with them or text them, and that's permissible. It's advised that you have your residents and fellows track their telemedicine visit numbers, and that obviously not have them bill for time-based billing codes in a training program. This also can be useful for your patients that, your residents and your fellows, that may be quarantined, so they can participate in telemedicine at home. And we've been using this at our facility for noon conferences and for meetings, just to kind of help with social distancing and making sure that your staff and providers are appropriately being careful. So I again just wanted to mention the FAFP COVID-19 resource page, which has a lot of very useful telehealth resources. I think the AAFP website and the ACP website are excellent, and so if you'd like more information, you can go there. And again, with the payers, as this is changing day to day and week to week, definitely a good resource for you to look at. And then that was the didactic portion of our webinar. So now we're going to spend some time answering questions that we've received from the audience. And I'm gonna, Dr. Julie Brady Roberts, are you there?
Hi, this is Dr. Julie Roberts. I've been typing a lot of answers to questions. I'm not sure if they're making it back to the audience or if we're going to read this off. I'll ask Adam, who's been organizing this, how we're going to go about the question and answer session.
So
yeah, unfortunately that, oh, go ahead, Adam, I'm sorry.
No. The way that we have it set up right now is I've been texting them through the chat box, and whatever we can get through via either the ones that were sent prior to the webinar or the ones that I've sent, whatever we can get through in the next 20 minutes, we'll get through, and then Jennifer and I have been collecting them, and we will make sure that every question that was sent in gets answered and either gets a response to the person that submitted it, or we'll post them as a Q&A document with the webinar after the Enduring is posted tomorrow.
Well, this is a great talk, Dr. Jenkins. I really appreciate everything you've put into it.
Yeah, and I'm seeing one of the questions that you responded to, someone asked, how do the Medicare reimbursements for 99214 virtual visits apply to commercial Medicare, such as Blue Cross Blue Shield Medicare? And
so that's a good question. Currently, from my understanding, is that all commercial and non-commercial Medicare are supposed to be paying at parity as long as it's Medicare. And parity means you get paid the same, whether it's a face-to-face visit or if it is a virtual visit. However, I mean, I'm a believer that until you've dropped a bill and you've seen the money come back, you don't really know. So, but that is the word that we're getting. However, that does not apply to commercial. And I'm not talking about commercial Medicare, I'm talking about just commercial payers in general. So I know that you had a slide that was showing the multiple different commercial payers that are now paying telehealth visits. And one thing you have to remember in the state of Florida is that they have agreed to pay, but they have not agreed to pay at parity. They have agreed to pay what you have contracted with the payer. And that is a very vague language. So they may say that they will pay a 99214, but if your contract with the payer says that they will pay a 99214 at 20% of a face-to-face visit, you may be getting paid much less than a true 99214.
Yeah, and one of the questions too, which I'll respond to because I've had a lot of people ask me about this, that even if you have 30 seconds of video, can I still bill a video visit? And the answer is yes. And I wanted to add something to that because, you know, I've had patients in the past say,
it's about having video that is quality. And that's where you have to decide what is quality. It's not about the amount of time on the video. It's about the quality of the visit. So a telemedicine visit by definition is, did you see the patient face-to-face and have a video visit? So if you saw the patient face-to-face and you feel that for the quality of the visit, you got enough of the face-to-face that you can continue the visit by some other means. You can call them or whatever to finish the visit. So say you were seeing them for an anxiety follow-up. You saw them, they're well groomed, they were smiling, they were joking around, and then your video crashed. You're not able to get it back up, but you're able to get them over the phone. For that visit, you've eyeballed them. They look great. You finish the visit over the next 15 minutes. They want to stay on the same medication. Their PHQ-9, their GAD, everything is perfect. You're not going to change anything. You're going to keep a 99213 based on complexity, time, refills that you sent. You have met everything for a telemedicine visit, even though your telemedicine virtual visit crashed. You do not have to change that to a phone visit. You're actually underbilling yourself.
Yeah, and I wanted to say too that the video visit, you're going to have patients that might feel uncomfortable being on camera the entire time. We as physicians are very capable of determining whether we need to see something via video or if we're comfortable getting a lot of our information via audio. So the requirement in the legislation is there should be some eye-to-eye video there. But if you're addressing an issue that you don't feel like you need to gather more data via video and you've met your even 2 seconds of eye-to-eye requirement, then it's absolutely appropriate to bill at the level that you're going to bill, because we as physicians are very capable of determining, is this appropriate management based on the data that I'm getting.
Exactly.
And one of the other questions, that I'm seeing is on informed consent. And that is something that I should have touched on, because some of the software, and I'll tell you, the legislation really has relaxed what software you can use, and so you do not need to meet the stringent HIPAA requirements that used to be required. And so that's why we're saying FaceTime is okay, Skype is okay, but there should be some documentation of privacy in that you're telling your patients, telemedicine has different privacy implications than an in-person visit. When you're doing telemedicine, you could have somebody right next to the patient, and if you don't see them on camera, you're not going to know that. So a lot of the software that we use will have that embedded in the system, and you just have to find out with the platform that you're using, is there already informed consent? Is there already a privacy statement built in that the patient is going to see or the patient is going to check box? And if it's not, then that's a dot phrase or some type of scripting your staff can do to make sure they're aware that telemedicine is a little bit different than an in-person visit. Just looking through some of the other questions that are on here.
I'm trying to remember. There was one question that I thought was interesting. That was one of the earlier questions that came. I'm scrolling through them. It was actually about how can I assess a physical parameter for a patient suffering from congestive heart failure. I would want respiratory rate, pulse oximetry, blood pressures, peripheral edema, cardiac auscultation, ways to check for volume overload. Some of these you could check with very simple measures. I mean, you can have the patient on their own check daily weights on just a very cheap blood pressure, like just a cheap scale at home. That would show, are they starting to get volume overloaded? A lot of people have a blood pressure cuff at home. They can report their own blood pressure to you. A pulse oximeter is about $20. You could get one of those on Amazon. You could get one of those at Walmart. So a lot of these can be self-reported by the patient quite easily, very inexpensively. You can actually take the phone or the computer or whatever video device the patient is using, have them point it at their legs, have them see if they have pitting edema, push on their own legs. You can watch how they're breathing. Are they having respiratory distress? But if you really want some just grade A, excellent information, there are actually very highly integrated tools out there. One device is called TytoCare. And I'm not trying to sell anybody anything. I'm telling you about it because it's actually available to the patients without a prescription. It's at Best Buy for $299. Patients are buying these devices. And when Dr. Jenkins talked about store and forward, this is like the Lexus of store and forward. They can actually store and forward heart sounds, like a stethoscope, lung sounds. They can store and forward pictures. They can store and forward their pulse ox, their blood pressure, everything to the physician. And more patients are buying these, especially pediatric practices. The patients are store and forwarding throat exams, ear exams. Elderly geriatric practices, they're store and forwarding the COPD and like CHF exams to the practicing physicians. And I was quite shocked to find out how many patients actually are having these at their homes.
Yeah, and we got another question from a resident at Eglin Air Force Base, and he was asking that they're saying they're ramping up their telemedicine use and asking specifically about resources to teach residents and faculty the very basics of telemedicine. You know, there is a lot of very good resources out there, and I would definitely start with this PowerPoint because the links from this PowerPoint, really the physical exam videos would be where I start. I didn't go into a lot of detail about that American Well website, but there's several videos that talk about the basics of telemedicine and what you want to consider before you start initiating your first telemedicine visit. And that's a really good place to start. I'll tell you as well, I'm happy to share that we've created a website for our residency program that I've made public in the short term for people to look at that has a lot of the 101 basics of telemedicine. That website is called turleytelemedicine.com. And so if you wanted to look at, from an academic perspective, how to create a curriculum and how to teach your residents and trainees the basics of telemedicine, that may be one resource. And I apologize for the silence. I'm just looking through some of these other questions that were posed. One of the questions was, will these patients have copays that they may get billed if they have not met their deductible? So through this 1135 waiver, well, the answer is yes, that is very possible. Under some payers, including Florida Medicaid and others, providers can potentially waive copays and waive some of those fees, but it really does depend on each payer. So unfortunately, that's something that you have to look at each individual payer for information.
Yeah, right now, a lot of the payers are saying that the COVID diagnoses will likely be waived of copays. However, there's very, very vague scripting on what that means. Does the patient actually have to have COVID diagnosed? Is it positive COVID only? Is it people that are suspected for COVID? We're not sure. So at this point, the safer bet is probably to say copays apply, deductibles will also apply. And then if all of the COVID diagnoses and suspected COVID diagnoses get waived, that's great.
Well, I think that was kind of the main topics that were posed at the end of the webinar. Adam, are there any other questions that maybe we missed?
That was all the ones that I had been able to grab that came through the question box. Like I said, our plan is Jennifer and I have grabbed every question that came through. We also grabbed the answers that Dr. Brady Roberts texted me. We'll compile a list of the questions and answers and have you all review them, and then we will either reach out to each person that asked them individually, or we'll post all the questions and answers that we got for the whole presentation, along with the handout of the slides, the audio recording, and the question and answer sheets, probably by Monday at the latest.
All right, well, I just wanted to say thank you so much for giving us this opportunity to give back to our fellow family physicians. And again, if you have any questions, please contact the FAFP and let us know. And we want everyone out there to feel comfortable and to be successful. So please reach out and be safe, and God bless.
Thank you, Dr. Jenkins. That concludes our webinar for this evening. Thank you.